So are you seeing the dengue patients this season from anywhere?
We are seeing in Chennai.
Yes, sir. We are seeing in Coimbatore, sir.
In Hyderabad, they are seen in Hyderabad plenty.
Tarun Saab, good evening.
Sir, good evening.
Because luckily we are not facing much this season.
No, Bangalore, they are seeing a lot of cases.
Yeah, that I mean, even about a month back when I
Yeah.
interacted, then also I heard.
Even in June, most hospitals
Yes.
in Bangalore had a lot of dengue.
Yes.
This time, maybe in Chennai, it is less, but it's still a long way to go. Once the rains come, we don't know.
No, we had quite a good amount of rain over the last maybe a month. Still,
Maybe
let's hope.
I don't know. This year, I don't know. I don't know whether it is true in Mumbai, whether the monsoon increased the infection rates or it did not. I don't know. I was told that.
Okay. At present, the hospitals are full. We are having large number of dengue. This year we are seeing falciparum malaria.
Oh.
Some parts of Mumbai, chikungunya, and flu is definitely ongoing.
But less than previous years, am I right?
Chicken more than the month we are seeing more. Yeah.
No, but last 3 months, even taking into account, but most years we are not busy. This year, I thought we have had less cases everywhere. I don't know. Less infections. I don't know.
At least we had less infections.
No.
Yeah, maybe Hyderabad is different. Yeah.
Sir, all the hospitals of Hyderabad are full. There is no vacancy in the PICU or in the emergency rooms.
Oh, that's very
flooded. It is flooded.
So that's
the presentations are entirely different. There is a combination of dengue and chikungunya going on.
Double whammy.
Yes, the dengue and hand, foot, mouth disease.
Hey,
so
good
these
evening,
combinations are going on.
Good evening. We are now live. Sorry, we are now live, but the link has changed, YouTube link. So I've just shared the link to all the groups now I'll be sharing. So we can start the proceedings. Dr. Darul sir, you can welcome.
Yes, sir. Should I start?
Yes, please, sir.
Okay. So this is the seventh the title has been put correctly and the participants are very good, and Dr. Chaudhary is well experienced and he is going to see what are the things we are doing wrong in managing a pyrexia of long duration. The definitions of pyrexia of long duration are varying, and hope that all the panelists will come to a conclusion and share us the knowledge. Over to Chetni.
Yes. Good evening, all. Welcome to another link of Super 11. And for this, we have a wonderful panel today. And as we are trying to satisfy the ID consultant as well as the general pediatricians having a more of a ID cases or in routine day-to-day practice. So what we have tried to select the cases or other topics according to that. So today what we are going to talk about is the pyrexia of unknown origin. And we know that this is a real challenging cases many a times. And in order to rather in attempt to treat it or manage it faster, rapidly, we err on the side of doing some common mistakes or silly mistakes. And that's what we are going to discuss. And Dr. Jaideep Chaudhary is the best person to moderate this session. And we have very, great pleasure to welcome all the panelists. Firstly, thank you, Dr. Danya. She was approached for last episode, but unfortunately she was not available. So she agreed for this episode. Thank you so much. So then we have Dr. Neminathan, our old senior person from ID chapter. Welcome, Dr. Neminathan.
Thank you,
then
sir.
We have Dr. Sija Shugunan. I hope I pronounce it properly. Sorry for that. And because of that, I was not finding your number because I was typing the wrong spelling. So thank you, Dr. Shija, for joining at the last moment because I was trying to contact you 4 5 days back. but couldn't get the number. Then thanks to Dr. Rajendra, I got your number, and you are great. Thank you so much. And lastly, as it is a pyrexia of unknown origin, and we know that most common differentials comes like rheumatological. So who else than Dr. Shikha can be there on panel? Welcome, Dr. Shikha. She is a pediatric rheumatologist, so your inputs will be valuable. So with the blessings and permission of Dr. Bala sir, who is the backbone and the brain behind this particular Superlink, Super 11, I request Dr. Jaideep to start the proceedings. Thank you so much.
Thank you so much. It's a pleasure to be a part of PIDA and the Super 11 series. Thank you, Dr. Ranganath, the chairperson, and of course, Dr. Chetan. Now, currently, always when the secretary's name is pronounced, then the adjective added is dynamic. But I would like to add charismatic Chetan as the secretary of PIDA, who has been really doing wonders, and we are looking forward to the quiz. So let me share the screen just 1 second. Yeah, I hope the full screen is visible.
Yes.
Yes. Yes.
Yes, sir.
Okay, so the topic as assigned by the office bearers of PIDA is prolonged fever, a case-based discussion. So rather than theoretical, we will focus on some very typical cases of prolonged fever. And I'm fortunate to have already introduced the panelists, the esteemed panelists, Dr. Dhanya, Dr. Neminathan, Dr. Shikha, and Dr. Sija. So it's absolute pleasure. And about the common causes that we face in day-to-day practice in our prolonged fever, mostly these are infections like the typhoid presenting as a prolonged fever, of course, tuberculosis, leptospira, rickettsia, brucellosis, hepatic abscess. I mean, pus somewhere, pus nowhere, pus under the diaphragm. So it's a common saying we had in UG. Infective endocarditis. Just I would like to share. Right now, we are having a 2-month-old baby who presented with fever and disproportionate tachycardia. So of all the investigation, echo was done initially, and it showed evidence of endocarditis. Then of blood culture, it came out to be positive, and right now the child is on antibiotic. So though, because it was not a prolonged fever, so I haven't included, but infective endocarditis should not be missed. Of course, some abscesses, and among viral, EBV is a common offender, and right now, over the past few years, adenovirus outbreaks have been occurring. Then there are fungal and parasitic malaria, usually do not present with prolonged fever, but sometimes it may pose a challenge also. And of course, as Dr. Chetan told, rheumatological diseases, yes, juvenile idiopathic arthritis, rheumatic fever, SLE, particularly as once Dr. Sikha was discussing with me that once a child presents with prolonged fever, it's absolutely essential, as we examine the throat, we examine the mouth also very well. So there may be some ulcer which may suggest SLE that should not be missed. And among neoplasms, of course, leukemia, lymphoma, they are common causes of prolonged fever. Drug fever by exclusion, sedum sickness, hypersensitivity pneumonia. Granulomatous disease is a condition often overlooked. And then there are miscellaneous conditions like Kawasaki's, inflammatory bowel disease and others, Kikuchi's disease and others. So with this, we will discuss few cases as already we have committed. So it's a 9-year-old boy. Mind you, this photo is just before discharge. It's not the admission photo. I don't have the admission photo. 9-year-old boy, intermittent fever for 2 weeks, high grade since the last 1 week. The boy was being treated outside by homeopathic medicines and on admission looked sick with liver 5 centimeters, spleen 3 centimeters. May I ask Dr. Neminathan, so how to approach this typical presentation of prolonged fever with hepatosplenomegaly?
Yeah. Thanks once again to PIDA team. Thank you, Jaideep sir. Thank you, SP sir, Darura and Chetan. So this is basically this pre-adolescent school-going boy who has FUO, and also hepatosplenomegaly, who is sick requiring hospitalization. With this background, the most important thing is I like to go a little deeper into the history. That's very, very important. Whether there is a documented fever in the first week, and whether
Sir, all
the
are
child-
documented fever. There is no question
Yeah.
about all are documented.
Yeah. If there is a history of travel to forest or falls or anything that could suggest some illnesses like scrub typhus, or family members having a disease, or a contact with a person with a chronic illness, or the vaccination history will give me a clue. And if it is a biphasic nature, child was afebrile for a period of some time, and then the child getting a fever that is worsening. Could be second part could be immunological like dengue or a leptospiro. And if there is a jaundice, I like to know whether there is a lymphadenopathy or anemia or a petechiae or purpura with a bony tenderness. And of course, the most important thing I like to do is thorough head to foot examination after undressing the child. Because many times we have missed scrub typhus and the hidden areas where we have missed. So most important thing is thorough examination. And the second important thing that as pediatrician, I like to do is do a repeated examination, because many times repeated examinations, some things comes to surface later. And another thing, this child having a hepatomegaly, I like to look at the consistency of the liver. If it is firm, probably it swings the pendulum towards tuberculosis. If it's a hard malignancy, and if it's a tender, probably in this season, dengue. And of course, we need to look at the joints. That's very, very important. Sometimes you can have a hepatomegaly with neck veins. You have to think of congestive cardiac failure. And another important thing that we fail to miss is to take the history of rash. Sometimes it's an evanescent rash. So with all these things, I'll make an empirical diagnosis, whether it is infectious or non-infectious. I like to do some basic investigation, first line investigations like CBC, CRP, ESR, urine microscopy, and including cultures. And of course, I'll do PS study and abdominal ultrasound, malaria parasite.
Yes, sir.
So
So
my
we will come to the
differentials-
investigation, sir.
Yeah.
Sir, great wisdom that you have shared, the importance of examination.
Yeah.
Basically, a prolonged fever, a sick child, hepatosplenomegaly. So probably we should think of infection as the first diagnosis rather than non-infectious, because the child is sick and there is also hepatosplenomegaly, as sir you have told. Now, these are the investigations that were done before admission. See, there is hemoglobin is persistently low, WBC count is low. Once SGPT was done, it was 80, and differential count, you can see it was neutral lymphocytic mainly, though not indicated, but it was done outside the Vidal and it was 1 in 160 positive. Not sure whether it was tube or slide. Let us not go into the discussion at all, because Vidal is not recommended. Bactec was sent, and the injection ceftriaxone was started at 100 milligram per kg, and the child showed some improvement. Now, Bactec culture, as most often happens, it showed no growth. Chest X-ray was normal. USG, as Dr. Neminathan already advised, showed mild ascites with hepatosplenomegaly. The child stabilized initially, but on day 4, the child showed sudden deterioration. The toxicity increased, the fever spikes increased. So meropenem was started in place of ceftriaxone. Shija ma'am. Dr. Avaisha, if you could please mute your audio. Thank you. Dr. Shija ma'am, now this typical picture, that initial improvement, then sudden deterioration, and of course meropenem was started. So is it MDR typhoid?
Thank you, Team PIDA, for this wonderful opportunity. Sir, as far as this child is considered, as you rightly pointed out, someone presenting to you with 2 weeks fever, and that fever is progressively increasing, and the sickness of the child is increasing. So definitely, infection definitely comes to our mind as the first possible differential diagnosis. Regarding it being an enteric fever, yes, clinical presentation is consistent with enteric fever. That is initially low-grade fever, then increasing sickness, that is consistent. But when you really look at the counts, in fact, I would not be really happy to consider enteric fever when you have that eosinophil sitting at 6%, because classically we are expecting an eosinopenia. So that is one thing that I would not like to consider because of that blood routine there. Then, as you already mentioned, Vidal is nowhere going to guide us whether it is enteric or not, because there are a lot of situations where you would get a false positive Vidal, including a previous infection, a vaccination, and even antigen cross reactivity is also there. But what bothers me in the particular setting that you have given is a child initially improving and then deteriorating, associated with cytopenia and transaminitis. So when the counts are going down and you also have a transaminitis coming up, then secondary complication like an infection associated HLH would always be in the back of mind to really rule out in such a situation.
Thank you, ma'am. So the point is that start converting or escalating to meropenem is justified because the child has deteriorated. But definitely, we just cannot sit back and consider it just as MDR typhoid. We have to look beyond. So now what happened? Pallor increased, the child became icteric, there was mottled skin, hemorrhagic rash, and abdomen distended. Right now, we have to refer this case to Dr. Shikha Agarwal. So, Dr. Shikha, do we go for any further investigation, and what investigation, or we just diagnose it clinically?
So I think Dr. Sija mentioned very nicely, sir, that we have a child who is already running fever and the child gets sicker, deteriorates and develops this rash. And we clearly can see this is a DIC-like picture which the child is developing. So we see that there is a cytokine storm syndrome that we are anticipating in this child. So of course, we need to work up, we need to investigate in that direction whether the primary cause is infective cause or it is any other rheumatological cause. But now at this point of time, it is a DIC-like picture. So in the routine investigations that we do, we would always like to see whether the ESR is falling or not. So normally with a sick child, when there is fever, the ESR should rise. So a basic investigation, simple as ESR, which is falling in a child which is having fever, will indicate there might be a cytokine storm and a mass-like picture that we are seeing. Of course, beyond that, we would do the fibrin degradation products, the D-dimers, the ferritin levels, the triglycerides levels. So one stepwise we do, if we see the ESR falling, then the next step we do all these investigations to prove or disprove a mass-like syndrome. In the primary investigation itself, we see that there is a low TLC platelet count towards, if it is falling, and it is indicative that the child is progressing towards mass.
So what happened is in front of our eyes, this was the chest X-ray. Ferritin was more than 20,000, triglyceride 391. You see lipase, LDH, fibrinogen, FDP, and this is the picture. So what you were suspecting and we were also thinking about, it has come true. This is an HLH. Is it, Dr. Shikha? And if at all we, other than ESR, we have to go for establishing the diagnosis, do we need to do all this battery of investigation, or in a resource limited setting, we can do with one or two investigations only?
Yes, so you're absolutely correct in asking this, sir. So all the investigations are not required. Even in mass criteria, they mention as a bone marrow, but these investigations are not mandatory to prove or disprove a mass. They even say the criteria, at least 2 of the 5 criteria, if they are met, then we can diagnose mass. But mass is initially a clinical thing that we suspect, like you said in the first picture itself, when we see a DIC-like picture in a deteriorating child, that is the time you suspect mass. And if you see cytopenia setting in, if you see a ferritin rising, then you can diagnose as mass and treat it.
So thank you. So at least a typhoid getting complicated or an infection getting complicated, there is always possibility of a secondary HLH, and that we have to be on the lookout, and we have got some idea. We move on to a next very small baby, a 5-month-old baby boy, fever, slight cough and cold for 20 days. Now, in between, the baby was hospitalized twice elsewhere and received multiple antibiotics. But then the condition deteriorated, had an episode of convulsion also. Investigations done outside few times were normal count and normal CRP, and this was the chest X-ray that was done previously. Now, on admission, the baby looked drowsy, the pupils constricted, there was tachycardia, BP was high, respiratory rate high, Saturation with oxygen was 100%. There was hepatomegaly. Other investigations were sent, and this was the external admission, and ceftriaxone started as the first antibiotic. Now, on day 2, the condition deteriorated. There was increasing distress, falling saturation, BP became low. The baby had to be intubated and ventilated. Inotropes and sedatives were started. Dr. Nevinathan, what could be the cause of this deterioration in a child?
Yeah, I can go back to the first slide, sir. Yeah. So this is a young infant. Probably this minor cough and cold, probably you have to take a history of whether the child was born preterm, there is a GARD, that possibility is there. And also sometimes we need to think about congenital anomalies like tracheoesophageal fistula. Sometimes early Weezer can have multiple episodes of cough and fever, or
Sir,
could
from
be
the history that we are having, is there anything very relevant that we can consider?
Yeah. So the hepatomegaly can be, second slide, hepatomegaly can be a push down liver. So it may not be a true hepatomegaly. So coming to the worsening of the condition, I would definitely think this child with a pneumonia worsening is definitely a complication of pneumonia. I first think it is considering the age, the pneumococele that has ruptured causing pneumothorax, pleural effusion, empyema, lung abscess. Sometimes necrotizing pneumonias can present like this. Young age, you can have a primary pulmonary hypertension and air leak syndromes. Sometimes they can have systemic symptoms like hypertension, shock, all those things associated with complications. Okay. So I would think of a complication of a pneumonia.
Complication of pneumonia is your first diagnosis because the child had respiratory complaints. Now, meropenem and vancomycin was escalated. Total count was high, CRP was high, sudden desaturation with decreased air entry on the left side, so that you can see in the X-ray to the right, wide bore needle was inserted and water seal drainage was given. Now the backtake blood culture showed carbapenemase resistant Klebsiella pneumoniae. I mean, this probably was the fallout of the repeated admissions and the antibiotics that the child has been taken, that we are getting a carbapenemase resistant infection in a 5-month-old baby, maybe an hospital acquired. Now, Dr. Shija, which antibiotic now in this scenario?
Okay, so now we have a child with a Klebsiella pneumonia, carbapenemase resistance. So this particular slide has two problems for us. One is, we know it is carbapenem resistant, but we don't have the data what is the MIC. Because even when you are carbapenem resistant, if your MICs for carbapenem is less than 8 or 4, you can definitely think of escalating the dose and giving it as an infusion. That is one possibility, but that we don't have right now. So that means we need to go for a second line drug. Now, what are the options for empirical therapy of a carbapenem resistant Klebsiella pneumonia? Here again, your empirical therapy options would be a colistin, a polymyxin, tigecycline, or ceftazidime avibactam. But which to choose among the second line would in fact ideally depend on if you knew that which was the carbapenemase enzyme. Was it KPC? Was it New Delhi metallo-beta-lactamase? Then also you may be able to choose one, that is which one to choose among the second line drugs. But here one thing I would say, we should not forget that this child had initially presented with a seizure. And all the second line drugs are in fact very poor CNS penetration. So in case the seizure was not due to hypoxia, but was also a part of a spectrum of a disseminated infection, then would always like to have that Miro sitting there. And that too, Miro when combined with second line drugs are found to have a better outcome. So which second line drug would you choose for? If you want to choose between a colistin and a polymyxin, I would personally go for polymyxin because of the better safety profile, less renal toxicity, better PK/PD, as well as you have almost similar efficacy. Both are same. One is a prodrug and the other is not. But I would always want to give the first dose as a bolus dose and wait for the culture and sensitivity report to decide further modifications what I can do.
Thank you, madam. Just as a part of investigation, CSF was also done in this child, but CSF was sterile. So now colistin was started. There was no improvement of inflammatory markers, fever persisting, high ventilatory settings. And after 72 hours of cholesterol, chest X-ray showed further deterioration, and bronchoalveolar lavage was done and sent. Dr. Dhenna, this BAL revealed a heavy growth of pan-resistant Kleb pneumonia, as you can see, and this is the report that's in front of our eyes. So what are the treatment options, Dr. Dhenna?
So what we practice is that if a lab informs us about Klebsiella pneumoniae and we think that it is potentially carbapenem resistant, even when there is growth in the culture, we do definitely want to know the mechanism of resistance. So we generally ask the lab, first of all, I mean, here it has been identified as Klebsiella pneumoniae. So the mechanism of action of resistance could be OXA48 or NDM. And in OXA48 alone, we use ceftazidime avibactam. But if NDM is positive, then we have to go for a combination of ceftazidime avibactam plus aztreonam. What is important is when the orders are written, we need to specially instruct how it has to be given. It has to be given both at the same time. So the infusion has to go at the same time through a wide tube or through the three-way connector. So both infusions have to finish at the same time to be effective. So these are colistin sparing drugs. We are nowadays not using polymyxins much because it works beautifully against Klebsiella pneumoniae. Now, having said that, if it is just gram negative, you don't know whether it is Klebsiella pneumoniae, and you are expecting carbapenem resistant, it is not, one must remember that you need to ask the lab whether it is lactose fermenting or non-lactose fermenter. Because non-lactose fermenters like Pseudomonas or Acinetobacter or Burkholderia can have additional mechanisms of resistance, and we cannot completely rely on gene expert Carba to decide the antibiotic. But the baseline is for Klebsiella pneumoniae, drug of choice, carbapenem resistance, is ceftazidime avibactam with or without aztreonam based on the mechanism of action.
Now, if the gene expert Carba is not possible, then what could be the choice of antibiotics in this situation?
Then we might have to go for a combination. Gene expert Carba, the advantage is the reports are available in just few hours, 2 or 3. But if it is not available, it's better to consider it could be NDM and go for a combination.
Yeah, because that combination of Oxa and NDM is quite common in our part of the world. So, and that's what happened. Both ceftazidime, avibactam, and aztreonam started, and the baby showed gradual improvement, and this was discharged. Now, moving on to a 7-year-old, a much older boy, 7-year-old boy, fever, which was intermittent for 2 to 3 months, a low-grade fever, intermittent. There was some cough. A swelling was noticed 3 centimeter into 3 centimeter, tender over right costochondral junction. That's for the last 10 days. And there were multiple cervical and few axillary lymph nodes, about 2 centimeters. Liver was enlarged, spleen was enlarged. Dr. Neminathan,
Yeah.
what do we do now?
So in this particular school-going boy with fever of 2 weeks and cough of 2 weeks, with multiple lymphadenopathy and hepatosplenomegaly and probably an abscess in the costochondral junction, the first thing that comes to my mind is to think of tuberculosis, and I'll ask for history of weight loss or contact with tuberculosis, and try to get some microbiological diagnosis. And suppose if there is if possible, I'll do some tissue diagnosis to prove my diagnosis. And also, if there is an underlying comorbid disease like diabetes or on steroids, I'll think of other organisms that can cause abscesses like melioidosis or brucellosis, or other organisms that can cause exposure to animals. History also will help me. So I'll keep these organisms in the back of the mind in this particular child.
But there is a swelling over the costochondral junction also. Definitely, tuberculosis has to be ruled out. We can do gastric lavage, and we can do for CVNet and all that. But we must be very cautious in approaching. Just cannot start an ATT offhand. So investigation revealed hemoglobin 8.9, WBC 8,000, platelet normal, TST was result awaited. Chest X-ray showed hilar prominence and backtech was done and Vidal test was done. It was also negative. Now fever was persisting. Still the child is sick. Sputum CBNAT was no AFB. Biopsy was sent from the lymph node, report awaited. SGPT was high. And also on repeat blood, we can see WBC is still 7,500, hemoglobin 8.9, lymphocytic. So broad spectrum antibiotic was started with ceftriaxone and cloxacillin. Now, Dr. Shija, what could be our approach now at this point?
Okay, so when we are going to the investigations also, we haven't really got something to really say that it is looking like something. Major concern is this is not 1 or 2 weeks. The history is around 2 to 3 months of fever. So that itself is something unusual. We're getting such a long duration of fever. So definitely in this case, one thing I would like to rule out is definitely a malignancy. You have the counts are low normal, but you have generalized lymphadenopathy with a hepatosplenomegaly. Then, of course, lymphoproliferative diseases would also come into a consideration. And something benign like Kikuchi can also be thought of. So I think I would wait for the biopsy report to really see where we are really going towards.
Right, ma'am. So let us proceed to another sibling of this child. A 4-year-old boy, pain in lower limbs for 14 days, pain in left shoulder with, you can see with the leaning for about 2 days, no history of fever or trauma. There was pseudoparalysis of the left limb and multiple enlarged lymph nodes. Hemoglobin was low, WBC 11,000, CRP was 5, SGPT again raised. X-ray left shoulder was done normal and there was mild hepatomegaly on USG. The third sibling, 2-year-old boy, had fever for 8 days, pain lower limbs, limping. There was history of TB in grandmother, that's 2 years back. Few cervical lymph nodes, again hepatosplenomegaly, and you can see the counts and the other parameters are more or less normal. Hemoglobin is slightly low. So I would like to ask Dr. Shikha at this point of time, is there a possibility of a rheumatological condition in these last 2 children?
So this is interesting thing. So 3 siblings when they are affected at the same time, one after the other. One we I think saw the first one with a 3-month history. Second one is around 1 month history, and third one has an 8 days. If you would have given me just one child, 8 days history with fever and a hip involvement, and their armamentarium is an acute infection. With 3 children, again we see that there is some common thing. A common infection, maybe an acute or a chronic infection, because the first child has having 3 months history. So tuberculosis, first thing which will come to my mind, because the child is having lymphadenopathy.
Sorry, ma'am, to disturb you. What I wanted to know that should we jump on a rheumatological diagnosis with these 3 siblings right now, or
no,
rheumatological possibility comes late?
Possibility will come late when 3 are infected together. So first thing would be an infective cause only leading to these joint
tuberculosis, malignancy, and then we have to think of other
malignancy. Also 3 children together, I would rather not consider.
Exactly.
Like it can be an EBV infection, or it can be a
but not rheumatological is unlikely. That's I wanted your opinion from.
Yes.
May I go to Dr. Dhanya? That can we get?
If I can ask one question here.
Yes, please.
Just sorry to interrupt.
No,
so
please.
The first child was started on a broad spectrum antibiotic when the child is having a 3-month history of fever. Would it be justified to start an antibiotic at that point of time?
Yeah, I mean that's definitely, it's debatable, but what actually happened I shared, so that was the condition, but that's debatable. I get to agree, absolutely. So Dr. Dhenna, the 3 siblings, can we trace any common thread?
Thank you, Dr. Jaydeep, for asking Dr. Sikha first. So she has ruled out rheumatological causes completely. So it boils down to infection, because I don't think any genetic condition presents this way. Now, among infections, if the 3 siblings have to be affected, Dr. Shikha talked about EBV, just that the first sibling has too prolonged course of fever, but it's a good thought. The other thing is tuberculosis. I have the greatest respect for this disease because it can fool anyone, anytime. So TB, I wouldn't 100% say no. I would look at, any TB screening, but then the other infections, it could be which comes with arthritis, lymphadenopathy, hepatosplenomegaly, brucellosis. I can't think of anything else at this point from infective point of view.
Right, ma'am. So what the history, I mean, after all these cases, then the history was taken, in much detail. Then, yes, they had cows and goats at home, history of raw milk ingestion. So the brucella was sent and it was positive for all these 3 kids. And the diagnosis was brucellosis. May I ask Dr. Neminathan that when to suspect brucellosis? Because, of course, in this type of presentation, we first think of tuberculosis, then malignancy, when lymphadenopathy, hepatosplenomegaly. But when should we suspect brucellosis? Because it's not that common.
Yeah, of course, when you have the history of prolonged pyrexia in a setting where they have got cow at home and where there is a history of taking cow's milk or paneer or
Sir,
something.
clinically,
Yeah.
history we have.
Clinically, obviously, when you have a combo of fever, arthralgia, hepatosplenomegaly, lymphadenopathy with abscess formation, sometimes liver abscesses in the liver and spleen, this combination will make you suspect. And another clinical clue that in your practice you can do is most of these children do have a typical autogenic sweat. That's very, very important clue in these children, apart from the history.
Okay, sir. So move on to another child. This is a 2.5-year-old girl, high-grade fever for 20 days, had cough also, progressive respiratory distress over the last 4 days, received multiple oral antibiotics elsewhere, and there is history of drowning in fresh water 24 days back. Now, is there any relevance to this history, Dr. Shija?
Because here what we are seeing is that 5 days, probably, or 4 days after the drowning, the child has started having fever and then progressed to cough, which has progressed to breathlessness. So you may have a link with drowning. That is, usually following a drowning, you can either aspirate the common organisms which are present in your oropharynx and causing a secondary infection, or it may be the organisms which are there in the water body where the patient has drowned, which may be causing a secondary infection. So you can have unusual organisms like Aeromonas or your Burkholderia, and even a leptospirosis with lung involvement, pulmonary hemorrhages, that are also possible in this kind. So we need to think in that terms also when we get a history of drowning.
So drowning should make us cautious that it can be some atypical organisms also. Dr. Dhanya, the child was sick looking, febrile. You can see there was tachycardia, saturation was low. There was decreased breath sound. You can see the chest x-ray. There was hepatosplenomegaly. Now, what are the possibilities? I mean, with this type of x-ray and with history and the presentation?
Yes, so we also recently had similar situation. So when there is history of drowning clearly, and when you have respiratory involvement with a hepatosplenomegaly, and the way there's a cystic lucency, it kind of fits into melioidosis, which Dr. Shija already alluded to. When this because we had a recent case, we had looked into what infections can occur with a fresh water drowning. So as Dr. Shija said, if it is fresh water, it's usually the commonly reported is Aeromonas, and if it is salt water, it is enterobacteria. But at the same time, in India we have to really think about, because India is endemic for melioidosis in many states, so therefore that would be top on the list.
Thank you. So this was the blood picture. Fortunately, blood culture yielded Wartholderia, but there may be conditions that we may not get anything by blood culture. That's why I wanted to discuss this case with the picture, that then we have to think of the possible organisms and plan the treatment accordingly. So, I mean, no discussion about the antibiotic selection. What was done actually, I have shared. Levofloxacin was added and the child responded. So the organism was Burkholderia, and we were lucky to get the blood culture positive. This is a 1 year, 5-month-old boy. Fever 101, 102 for 24 days. The baby became lethargic and less playful. There was no history of cough, loose stool, urinary complaints, or no contact with TB also. Past history was pneumonia at 4 months of age, more than a year back, was hospitalized. It was a term delivery, birth weight normal, neonatal period was uneventful, even the development was normal, present weight 8 kg, and the baby is mainly bottle fed. On examination, the baby had pallor. There was liver 4 centimeter, firm, smooth surface, regular, spleen was 4 centimeter, firm, heart rate was 120, and other things were normal. So, Dr. Neminathan, that again, how do we approach this 1 year, 5-month-old baby?
This is a toddler with nearly around more than 3 weeks of fever.
Yeah.
Probably with the market pallor, and it swings the pendulums with the PUO, with the market pallor, hepatosplenomegaly, more towards infections, particularly in endemic areas like malaria, or could be still be a HIV or CMV. And of course, I keep malignancy in the back of the mind. These are the things that I think are present.
Right. So hemoglobin was 6.5, WBC 6,000, neutrophil 30, platelet was low. So hemoglobin low, platelet low, WBC low. IgA was normal, anti-TTG antibody was normal. TST was 5 millimeter. You can see the chest X-ray normal, and the USG abdomen showed hepatosplenomegaly. The peripheral smear did not show any blast cells, as definitely malignancy was one of the DD. Malaria was negative. Again, LDH was done normal, blood culture sterile, urine normal, HIV, CMV negative. Now, even the Epstein-Barr virus was not positive. So, Dr. Shija, what could be the diagnosis with this type of investigations?
So basically now we are having a 1.5-year-old child with pallor, hepatosplenomegaly with thrombocytopenia. So everything pointing, as already everyone has said, that it looked definitely we would all like to rule out a malignancy here. Because pallor, hepatosplenomegaly, thrombocytopenia, that thing is definitely in the back of mind. And I would also like to consider a familial HLH, even though slightly we usually see familial HLH in young infants, but they may present to you in later life beyond 1 year also, again with pallor, hepatosplenomegaly or something. And immunodeficiency is also in the back of mind because there is a failure to thrive. So immunodeficiency means you may be landing up having unusual organisms also. So I think right now would like to definitely go for a bone marrow and see what the bone marrow culture and bone marrow aspirate report says.
Yeah, actually, with this type of picture, when most of the routine investigations are inconclusive, we have to go for further. Now, bone marrow culture was sterile and there was no evidence of malignancy. Dr. Dhanya, so at this point of time, what are the possibilities? Because we have ruled out malignancy, and yet we haven't got any other infections. So still, what are the possibilities that we can think of? Dr. Dhanya, please.
Yeah. So this is tough because so many tests have already been done, and now from it still infection can still be possible. So now the infections, chronic infections is what we can think of. You mentioned that bone marrow culture was sterile. We have not done any imaging for a biopsy.
No, that I mean, we will come in the next slide. But other than that, we cannot proceed right now without a proper bone marrow study. I think that's the message. So this was the bone marrow study, Dr. Dhanna. You see,
Oh.
the impression was histoplasmosis. This was what we got. So ultimately, what Dr. Shija told, we had to do a bone marrow, and then only we could get our diagnosis. So it was a disseminated histoplasmosis, and amphotericin B was given, and the baby recovered. So definitely, I think Dr. Dhanna would agree that is it a manifestation of immunodeficiency that we have to think, because it was a not a very thriving child, prolonged fever. So we did all the investigations. Your opinion, Dr. Dhanna, anything we have
Yeah,
left?
histoplasmosis is, always related most of the times with an immunodeficient. And first thing I would consider as HIV, actually, if that has been ruled out. But you have shown that the other tests are normal. So if HIV is also ruled out, then this is a case report to be done if you feel it's immunocompetent child who had
It was reported,
histoplasmosis. That's
actually.
very unusual. Yeah.
Yeah. Okay. So this is a probably much simpler case. 13-year-old boy, Dr. Neminathan,
Yes.
intermittent bouts of cough for the last 6 months, occasional low-grade fever documented, but low-grade fever, occasional, not continuous, very lethargic, suspected weight loss. There is no record of previous weight and no history of tuberculosis in the family. You see this child on presentation. Dr. Neminathan, what do you think of? What are the possibilities?
Once again, though there is no history of contact of tuberculosis, I would still keep in our country tuberculosis in the back of the mind. That I'll think of that. And I'll go all out to rule out tuberculosis in the form of gastric juice and other things. And of course, a cough of 6 months duration definitely will need other conditions to keep in the back of the mind. Older child, but still we need to keep of cystic fibrosis and other things. Sometimes,
Yeah.
yeah,
So I think
allergic disorder.
still TB comes as the first diagnosis to you
Yeah.
and to anybody. And
Yeah.
you see, this was the X-ray finding, and you can see the miliary shadows. Investigation was hemoglobin 9, WBC 9,600, ESR 32, TST was 8 millimeter, sputum AFB sent, and chest X-ray taken. Dr. Dhanna, would you, with this history presentation and this investigation, would you like to start ATT at this point of time?
No, especially from a city where multi-drug resistant TB is so common, we 100% aim for a microbiological diagnosis unless the patient is extremely sick. So I wouldn't be satisfied with the history and the present test reports. I would definitely go for find out the reports of the sputum. If necessary, look at any lymph node biopsy by doing a scan, but I wouldn't start ATT at this stage.
Yeah, this is the message actually I wanted to convey also, that yes, the CBNAT is easily available and we must go for a CBNAT and RIF resistance before starting ATT. ATT can wait for a day. That's not an issue. But ATT was started, the 4 drugs ATT. The justification of the admitting pediatrician was that there is a miliary shadow, there is fever, cough, poor weight gain, as per the criteria of the diagnosis for TB also, and the TST was borderline. So 4 drug ATT was started. Now the child showed initial improvement, but persisted to have cough and weakness, and even after 2 months of ATT, the repeat chest X-ray did not show any improvement. Shija ma'am, so what next? You can see the miliary shadow persisting.
So very interesting case. I think I would go with what Dr. Dhanya said. That is, just having a miliary shadow definitely does not prove that the child has a tuberculosis, because there can be other causes: a fungal infection, a parasitic, a malignancy can all present with a miliary shadow. So we have to go all out to get a microbiological diagnosis. So I would say that one is we can go for an imaging, look if there are any nodes, see by do a BAL, or we can see whether we are finding any mediastinal nodes. Maybe a bronchoscopic biopsy may be taken to get a diagnosis. So next step would be definitely 2 things. One is get a microbiological diagnosis somehow, and the next is take an imaging to see what you're dealing with. Even if we are not getting anything from the imaging, we may even think of advanced imaging like a PET scan may also be indicated, because on one side you may be thinking of a resistant tuberculosis, on the other side you're thinking that probably I'm not dealing with tuberculosis at all. So both these spectrum we need to handle at this point.
Thank you, ma'am. Thank you. And CT chest was done. This was the finding of CT X-ray, and bronchoalveolar lavage was inconclusive. What could be the plan for further investigation? I would like to put this to both Dr. Shikha and Dr. Shija. Dr. Shikha, whether we should go in any other direction other than infection, and Dr. Shija, also your opinion on this.
So like Madam already said, so in the first, the previous case also, ultimately you have to go for invasive investigations to get to a conclusive diagnosis rather than starting on empirical therapy. You're already an empirical therapy with ATT was given, not responding. So I would go with invasive investigation with this kind of a picture, lung biopsy or biopsy is required to prove or disprove. And even just ma'am said a PET scan to see if there is any uptake or these lesions which can be biopsiable.
Shija ma'am, any other opinion?
No, I think I'll go with the same thing. Only
Yeah.
thing, when we're taking that, we may send that also for a CBNAT, whatever specimen we are taking.
Exactly. So ultimately, lung biopsy was done after all the investigations, all the steps, and it showed papillary glands with densely stained colloid epithelial cells, and it showed thyroid tissue in lung biopsy. And then the thyroid gland USG was done, and ultimately thyroid scan showed follicular carcinoma of thyroid. Now, a miliary shadow, the cause for a metastatic miliary shadow is most commonly from a carcinoma thyroid. If we have to see of carcinoma, other carcinomas usually we have solitary lesions, but a miliary shadow from a thyroid follicular carcinoma is one of the main causes that we have to consider. We move on to another child, a 5-year-old girl, fever with cough for 2 weeks. Visit on day 5 of fever, oral co-amoxiclav was given, not responded, fever continued, admitted to a local hospital on day 8 of fever, hemoglobin 10, WBC 23,000, mainly neutrophilic, CRP very high, 151, and this was the chest X-ray you can see. Ceftriaxone vancomycin was started, not responded after 4 days. Repeat blood report, X-ray was similar. Gastric lavage, no AFB. USG, there was enlarged liver, minimal bilateral pleural effusion. Fever continued with cough, intermittent desaturation, so upgraded to meropenem and vancomycin. Dr. Dhanya, are we going in the right direction? So what's the management you would like to recommend?
At this point, I would like to consider further imaging of the chest, because that's where the localization has taken place. High counts, high CRP. So that would be my next step to know whether there's anything that we can get. Plus, of course,
at this point of time, infection comes first to our mind. Am I right,
yes,
Dr. Dhanya?
yes, definitely.
And I hope we are justified in giving meropenem and vancomycin,
Yes.
because for a broad coverage, which shows that there are the pneumonic shadows in the chest X-ray with high count and CRP. So definitely we have to go ahead with antibiotics. Now, CT chest was done. It showed streaky opacities, as we can see. Now, on questioning, the parents revealed, which they thought not of much consequence. 3 months back, the child had intermittent painful nodular skin lesions, and they had taken a picture also of that time, which they shared now. And there is a history of blood-streaked sputum during this total duration of illness, which they thought had come from epistaxis, and they considered it trivial. So these two are new findings. Dr. Shikha, is it related, this new findings, with that chest finding, and how to proceed in this?
Yeah, so of course, any findings, and if the child is suffering, we will never consider there are 2 separate diseases the child is having. We will always try to knit those things together, whether it is associated. And what I see here is the child is developing erythema nodosum like lesions. So these are lesions which are typical if I can see, there are shin lesions on the shin that the child has a picture of. So these are erythema nodosum-like lesions with lung involvement. So plus, if we see there is a fever going on, anemia, high TLC, high CRP, so definitely an inflammatory process going on. With erythema nodosum-like lesions, again, the first possibility is always infection, because streptococcal infection, tuberculosis infection can cause these lesions, plus chest findings like the cough which is going on. So ruling out infection is very important here. Once that is ruled out, then we consider secondary causes, rheumatological causes come into the purview.
The points to ponder, as you have already told, that high-grade fever not responding, worsening respiratory status, 2-episode hemostasis, raised inflammatory marker. So at this point, I hope Dr. Shikha will agree that we have to think of other investigations to link the respiratory and the skin findings. So how do we go about detecting the non-infectious causes of fever with simultaneous lung and skin involvement? Which investigations you would like to go for?
Okay, so two things. One is blood investigations. Of course, here, if we think non-infectious causes with such high CRP-SR and skin findings, the possibility of vasculitic disorders come into picture. So I would like to rule out whether it is an ANCA-associated vasculitis, and we have to be sure that we do an ANCA by an ELISA method, because a proper method has to be used. Nodules with these kind of things, polyarteritis nodosa, medium vessel vasculitis is also a possibility. With me, with any skin findings, if you have, the first thing we would always like to do is, since it's a skin, it's very easy to biopsy those lesions. So a skin biopsy will give you a lot of clues to what the disease can be.
So it started with an infection. Now we are moving to non-infectious cause. Yes, ANA, hepatitis B, C negative. ANCA was negative. Bronchoscopy was normal anatomy, mucosa congested, and hemorrhagic bronchoalveolar lavage. Microscopy was mixed inflammatory cells and hemosiderin-laden macrophages. Culture was no growth. Skin biopsy, as asked by Dr. Shikha, was done. Deep dermis blood vessels show neutrophilic infiltrates and nuclear debris suggestive of vasculitis. So it is ANCA negative, small vessel systemic vasculitis. Dr. Shikha, any comment on this? Yes, please. I will go to you.
Two things which I would like to comment here, sir.
Please.
One is, very commonly ANCA is not done by a proper method. So if it is not done by ELISA, we have seen patients where the first ANCA which done is negative, and if we do it properly by an ELISA method, it comes out to be positive. One, that has to be sure. Second, a deep skin biopsy, if I see here, deep dermis shows blood vessels which shows neutrophilic infiltrates. So even polyarteritis nodosa, which can give these nodular lesions, which is a medium vessel vasculitis, which has a spillover on the skin lesions, can be a possibility here. So, of course, I am sure this must have been rediscussed, whether there is a small vessel involvement or a medium vessel involvement, and a urinary finding must have been checked in this patient, whether the urine is normal or not. What an interesting case that it's a small vessel vasculitis which turned out to be.
Yeah, so starting with a typical pneumonia infection, we changed to antibiotic, then digged deep into it. So the message, I think, is that when there is some chest shadow and other findings, we just should not go on escalating the antibiotics, but rather searching for some other causes.
It's like retrospectively, you join the dots here. You see the child is having multi-system involvement.
Multi-system involvement.
Chest, right. Then skin also, having fever also.
Yeah.
Anything.
So 2-year-old boy, recurrent fever for last 8 months. There's a single painless solitary macule 4 to 5 centimeter on the left forehead for the past 2 days, and there is some abdominal distension also. Sick looking, febrile, moderate pallor, generalized lymphadenopathy, liver, spleen enlarged. Dr. Dhanya, what are the possibilities and further investigations?
So when you have a scenario of a recurrent fever since past 2 to 8 months, and clearly in the next slide, you showed multiple lymph node involvement and liver spleen enlarged. So it's clearly the child is having some underlying, probably some immune deficient disorder, which is causing fever recurrently. Of course, at this point, I would really look into how were the fever episodes, were they just simple viral, or do we have to consider an immune compromised condition where that child needed antibiotic every time, or some unusual growth of bacteria, etc. the further investigations, again, I would be curious about the macular rash that you mentioned on the forehead. That's pretty large. Can you please go to the previous slide? So that is what you have projected first. So it has to be something single painless. So it's not tender, and that too on the side of forehead. So
Not acutely inflamed, I think what you mean. It's not tender.
yeah, it's not acutely inflamed, but it's pretty large, 4 centimeter to 5 centimeter, to be an insect bite allergy or to be ignored. So this is something in the underlying immune compromised condition. Maybe, I mean, we need to watch for.
Oh, yeah. So let us go ahead. It's a lymphadenopathy. We have to think of malignancies, of course, infective cause. And Dr. Neminathan, this is the macula on the forehead, which gradually turned into edematous papule pustules within 24 hours. And next day, after admission, it was dark violet eschar with surrounding erythematous halo. So what is this, Dr. Neminathan? What are we facing?
Probably when you see such a big lesion, which is bluish in color with ecchymosis and granulomatous center, probably the first thing that the anatomical and the etiological agent I would think is Pseudomonas the first. Sometimes rarely you do get E. coli and Aeromonas that can present like this. And rarely, now South India is becoming a hotspot for Burkholderia that can also present like this. These three organisms I'll keep in the mind. And of course, this what you're looking at this is ecthyma ganglionism that has to be kept in the back of the mind.
Sure, sir. So blood culture and culture of punch biopsy from the specimen revealed Pseudomonas, and you see hemoglobin was 7.7, WBC 700, absolute neutrophil count was 462. Bone marrow showed myeloid hyperplasia, erythroid hyperplasia, increased megakaryocytes, and USG showed also intra-abdominal nodes. Dr. Shija, and then Dr. Shikha also comments, is it leukemia, and whether we should go for further investigation? Dr. Shija first, please.
Okay. So as already beautifully elucidated, that we did think of the initial setting, definitely immunodeficiency, definitely malignancy, with anemia, with significant cytopenias and thrombocytopenia. But what baffles here is that your peripheral counts are all low, but your bone marrow seems hyperplastic. So what is happening to the cells which are produced by the bone marrow? It's probably getting destroyed somewhere. That is why peripheral smear, it is less in number. So in that condition, I would not really like to think of a malignancy upfront, would also like to consider an autoimmune cause also here because of the hyperplasia there.
Dr. Shikha,
Yes, I totally agree with Dr. Sija here, and especially when the child is having 8 months history. Usually with malignancy, usually we will not see such a long history with 8 months going on, and here we see there is hepatosplenomegaly lymphadenopathy, that was the reticular endothelial system activation is happening. So of course, like ma'am suggested, we'll have to figure out where it is destroyed first and why is the WBC so low. So we'll, of course, nowadays it's very easily available to see a flow. Okay, what are the WBCs that you're seeing?
Right. So cervical lymph node biopsy was reactive hyperplasia, immunoglobulin levels normal.
Curious about the macular rash.
Yes. And the final diagnosis was ecthyma gangrenosum as the presenting clinical feature of ALPS. So empirically, piperacillin, tazobactam, and amikacin were started on admission, and then you see the culture that yielded, and it showed sensitive to colistin only and polymyxin, colistin, polymyxin. So it was then continued with colistin, and the child recovered.
I think it is not a very common, very rare presentation of ALPS presenting like a Pseudomonas infection.
Yes, yes, that's why I wanted to share. It's a rare entity. Going to another case, a 9-year-old boy, intermittent fever for 2 months, 100 to 103 documented, and usually 2 peaks per day with mild pallor, systemically nothing else, hemoglobin low 8, WBC 12,000, platelet 8 lakhs, CRP persistently high on 3 separate occasions done at intervals. Dr. Neminathan, how do we approach this fever?
Yeah, This once again is a child who is school-going boy with a fever, definite fever of 1 or 2. Probably each day is having a spikes of 2 spikes with a mild pallor and a thrombocytosis and elevated CRP are the striking features. In this child, I'll first think of rheumatological, and of course, I'll think of rheumatoid first. And of course, with thrombocytosis, Kawasaki, and other diseases, I'll keep in the back of the mind. I will keep malignancy and myelofibrosis. I keep them in the back of the mind also. But the first thing I'll think is rheumatological.
Dr. Dhanya, I would like to go to you next. We had urea, creatinine, electrolytes, liver function, all are normal. Even procalcitonin was done normal. Urine was normal. There was no growth on culture. CBNAT was negative. Chest X-ray, USG, echocardiography were normal. Scrub typhus, brucella, Epstein-Barr, normal. ANA not raised. Bone marrow aspiration and biopsy was also normal. So, Dr. Dhena, what next? Do we have anything left?
Yeah, so I think what is missing in this battery of tests for a PO, I would even before the bone marrow, I might consider an imaging further to understand. I mean, rest all have been done, so there has to be some focus somewhere. So either a CT chest with abdomen or PET scan or just to check for any lymph nodes or some biopsiable source other than bone marrow.
So, I mean, we have done a USG, but sometimes the USG also has some limitation. Maybe we have missed something. But other than that, we just cannot proceed into any infectious cause. Am I right, Dr. Dhanya?
Yeah, absolutely right. Many times, despite the chest extent sonography coming to be normal, we have some findings on CT imaging. But what is important for all to understand is when you are asking for such a test at this stage, you should always ask with contrast. So many times, this contrast is missed, and again, we are not very clear whether there were lymph nodes prominent or.
Yeah, the battery of tests were done. Now, ultimately, a whole body PET scan was done, which showed a large lobulated mass in the rectovesical pouch with intense heterogeneous enhancement. And there was without no evidence of any distant metastasis, and FNAC was inconclusive. So, Dr. Shija, what is this? I mean, what we have got in PET scan?
So with the limited knowledge, I would say that when you have an increased FDG uptake, it basically means that you're not dealing with the abscess. Because necrotic center, you may think that it is an abscess. It basically means you're not dealing with an abscess. You're probably dealing with a tumor or a polyp. That's what I would comment here.
Yeah. So, and this was the actually finding. It's a coronal and sagittal planes and rectovesical pouch with increased FDG intake uptake, as you have been discussing. Now, this was the histopathology. Dr. Shikha, I think we have to go to you. The histopathology of the mass shows stratiform fibrosis and obliterative phlebitis, suggestive of IgG4 related disease. It's an inflammatory myelofibroblastic tumor.
I
Dr.
think
Shikha.
related disease is not half as old as I am. It's just 20 years that it has been identified any which ways. So here we are getting something where there was fever, there was inflammatory signs, anemia, raised CRP. So like you said already, that sonography maybe missed a mass which was existing. And finally, you need a histopathology to diagnose that is an IgG4 related disease. So if I may say, inflammatory myofibroblastic tumor and IgG4 related disease are two different things. And this obliterative phlebitis. So basically there is an inflammation which is causing fibrosis and which is ultimately causing occlusion of the blood vessels around. And this histopathological diagnosis leads us to a diagnosis of IgG4 related disease. And we can do an IgG4 serum levels, which might be elevated in this patient to give to a conclusive diagnosis as well. Normally, when we see IgG4 related disease, we may see a salivary gland. So we have patients which have parotid swelling, or there is a raised amylase or a pancreatic pancreas involvement which happens with IgG. We have few patients who have aortitis, so there is a fibrosis around the aorta and leading to aortitis and obliteration there, which differential becomes Takayasu arteritis. So this is what IgG4 multi-system involvement can happen with IgG4 related disease. So here,
yeah,
please go ahead.
Yes, ma'am, please.
So that's what I was coming to think. So that when you're treating this, if this is a single involvement, so you can remove that surgically. Otherwise, steroid is one thing which is usually given IgG4, and it responds very beautifully to the steroids.
So we had to dig into. So whatever said and done, we have discussed a few rare cases of prolonged fever. But what happens commonly? There was a systemic review in 2011 with 18 studies. Now, the three most common etiologic categories of fever of unknown origin, the most common was infectious, more than half, like the TB, typhoid, the brucella, or the UTI, which sometimes goes untreated. Then next comes the connective tissue disorder, much less, is 9%. Among those, again, the common are the JIA, the Kawasaki, the SLE. Further comes the neoplasms, which is about 6%, leukemia, lymphoma being the commonest. And often 1/4 of the cases goes without diagnosis and the patient recovers, or sometimes it gets complicated. So again, prolonged fever, we have to think of infections and common infections or some uncommon infections. We have to decide on the clinical features, and other these conditions comes much less, but we have to be very cautious about that. So thank you, esteemed panelists, that we had some discussion on various causes of prolonged fever. And thank you, PIDA, for hosting this. Over to Dr. Chetan.
Yeah, sir has just left because of some social emergency. Thank you very much, sir. Excellent cases. Basically, almost you had covered all chronic infections, rheumatological conditions, malignancy, solid tumors, hematological malignancy, rather hardly few things left. Sir, some points from Dr. Bala, sir.
Please, sir.
First, hats off, Jaideep. Fantastic. Hats off to you. Brilliant. And your panelists are simply brilliant. And you covered the entire horizon of PU. Of course, 2 or 3 comments I thought I should make.
Please, sir.
There are 2 diseases which can get missed in the evaluation of PU. The rest all, we know PUO means, for a pediatrician, it's either infection, inflammation, or malignancy, or autoimmune disease, or miscellaneous, four groups. And majority of pediatric PUOs, unlike adult PUOs, are infections rather than malignancy. That point is well taken. The 2 disorders which are very difficult to diagnose, which can get missed, which can be disastrous if you miss, are drug fever. I'm sure Jaideep would agree. Drug fever is not easy to diagnose for the simple reason books might say that drug fever diagnosis is a diagnosis of exclusion. In the sense, once you stop the drug, the fever should go off in about 3 to 4 days, most drug fevers. But there are a few drug fevers, like, for example, your DRESS due to phenytoin or phenobarbital, or your carbamazepine hypersensitivity syndrome, pseudolymphoma. Even after you stop the drug, the fever may go on for 2 weeks. Eosinophilia may be there, may not be there. So good drug history, and notoriously, most drug fevers in the United States today are due to cephalosporins in children. So that is one point. Second difficult diagnosis, I thought, is Munchausen syndrome by proxy. In fact, Jaideep, I had seen one doctor's child who went on with PUO for 6 months, including PET-CT, everything was done. Finally, it was actually Munchausen. She was actually cheating all of us with the temperature recording by keeping the thermometer in the hot water, then putting into the child's mouth or axilla. So that is again going to be made out only by history. The third group, of course, you had given already one example of IgG4. Other than that is the autoinflammatory disorders. We are slowly seeing an increase in such disorders. For example, your periodic fever, aphthous stomatitis syndrome, and the Majid syndrome. The rheumatologist, madam, would know more about it. That's another area where difficulties in diagnosis occur. Interestingly, the so-called IgG4 disease, even the serum levels of IgG may not be diagnostic. You may have to go for genetic diagnosis. And of course, a trial of hydroxychloroquine might be worth in IgG4. I think one investigation I thought, which is often not done by pediatricians in PUO, most pediatricians, they do echo, they do PET scan, they do CT, etc. But they fail to ask the ophthalmologist to look at the eyes. But I have seen this happen. In fact, I have had an occasion to treat a child with jaundice and fever. We asked the ophthalmologist's opinion who picked up uveitis and choroid tuberculosis. It turned out to be tuberculosis. So ophthalmology opinion may give you a clue to the PUO in the form of uveitis or clues to tuberculosis. The last comment is, in any PUO, if you find a discordance between ESR and CRP, that is, CRP is negative, ESR is 100, you have probably only SLE or Kikuchi or probably ileal involvement of Crohn's disease as a diagnosis. In no other disorder other than these three disorders, you get a negative CRP with an ESR in hundreds. These are my comments. Excellent job, Jaideep, and your teammates. Thank you very much.
Thank you. Thank you, sir, for your comments. Dr. Vijay Vile, sir, is there, sir? A few comments from you.
No, I can only say, Jaideep, you have an exhaustive and exhausting collection of cases, and what a wonderful session, and so beautifully analyzed by all the three experts, and they were really, I mean, more than the final diagnosis, their approach, and that is what all the attendees would want to know, and that is what they dwelled in. It was beautifully conducted. And I always say, Dr. Bala is the expert of experts. I mean, his comments were so relevant, so relevant. Only thing is, only one comment on his comment. Do you really see drug fever going on for such a long time? What is the longest that you have seen? Drug fever?
1 month.
1 month, okay. Okay.
In
And
fact,
what was the drug?
I agree with you. Most drug fevers don't run for months.
Yeah.
They usually run for weeks. Since the topic is PUO, now the duration of fever in PUO has come down to 8 days. Most agree that.
That's true. Yeah.
So drug fever is something which can occur.
Yeah. And I cannot agree more on what you said, that it's not so easy to diagnose. Though say it's diagnosed by exclusion, we keep beating around the bush, excluding something or the other, and it really doesn't cross our mind very often. But drug fever is a common entity. Thank you, Jaideep, and congratulations.
Thank you, sir. Thank you. Thank you so much.
Thank you, Dr. Sir, few comments from YouTube. I cannot see the name, but there is written that ANCA negative vasculitis case, besides TB, consider pulmonary eosinophilic lung disease, fungal infection, sarcoidosis, hemosiderosis, fibrosing alveolitis, acute extrinsic allergic alveolitis, or PEP. All these possibilities he has added. I cannot see the name. And there is one more thing, the 6-month cough. There's someone has written that allergic respiratory conditions should also be thought of when there is a 6-month cough and we are not suspecting infection. So these were the comments from YouTube, sir.
Yeah, the allergic cough was, of course, excluded, and we tried to focus on PUO only. I mean, the cough, the cause for asthma or allergy was excluded, definitely. So, I mean, as a final take, any comments from the experts, Dr. Dhanya and Shija ma'am, Dr. Shikha, Dr. Neminathan, if you can just message for a PUO.
on the YouTube thing. So when you have a biopsy diagnosis of a vasculitis, lot of things which were mentioned, sarcoidosis and things like that, we rule out with that because the granulomatous lesions were not seen in the biopsy. And just for that comment. And for Joydeep sir, very good cases that you had and you discussed.
Any message? Please don't.
Rheumatological perspective, what I would say, in the first case, we learned that when there is a fever deterioration, always think that it can be something like a cytokine storm. And when there is multi-organ, I would always suggest that think beyond, it can be a rheumatological cause.
Thank you. Dr. Dhanya, please.
Yes, thanks. Actually, in PU, it's basically again revisiting history, because if we see the collection of cases, there were some important points which Dr. Jaideep highlighted, so it made easier for us to go along. But these things can be easily missed, like freshwater drowning or the consumption of raw milk. So these are all important pointers. So history is always at the top. And of course, prolonged fever is not ceftriaxone deficiency. So people just can't, okay, let's finish at least 14 days of course of ceftriaxone and then we will see. That's not it. If it's not going as per your expectation, you must start thinking out of the box and really evaluate why the fever is. And hats off to you, Dr. Jaideep.
No, this is the message from an infectious disease expert like Dr. Dhanya, that it is not a ceftriaxone deficiency. So, Dr. Shija, any comments from you on the?
I'd say it was a great learning experience for me, listening to everyone.
Overall message about approaching FUO. Any last comment? If you...
I think basically I would again add on to the fact that history takes the most important part. About your travel history, again repeated history and repeated examinations.
Thank you, ma'am. Dr. Neminathan.
Yeah, it's a PO is most common presentation of an uncommon presentation of a common illness, number one. And number two, you had to take history like an undergraduate and you had to do an examination like a postgraduate. You have to thoroughly address the child and thoroughly examine, and re-examination is very, very important because many findings comes later. So repeated re-examination is very, very important. And sometimes a single CRP will not be of use, not for PO, for a serial CRP will be of use. Will be of help. And that is, if you look at the kinetics of CRP and ESR, CRP rises first and then falls down early, and ESR rises later. Preferably, you can time the CRP and ESR for a PU.
Thank you. Dr. Manish, to...
Sir, Dr. Vijay sir wants to say something, I think.
Yeah, Jaideep, I just have a question to ask you. How many of your cases were treated as enteric based on Vidal, and how many were given empiric ATT?
No.
Not even one.
We do not rely at all on Vidal. Culture is the norm for any fever admitting in our hospital. But many a times they come with a Vidal report, and that too done on day 2 or day 3 of fever also.
Yeah, because one important message that most of the PUs which where diagnosis is delayed is they keep on receiving treatment based on Vidal or empiric ATT.
Absolutely.
Finally, Raman sir, want to say something?
Or nothing more to say. It's a fantastic, exotic cases. So it's a really learning experience for us. Good, wonderful panelists and wonderful by Jaideep. Thank you.
Thank you.
So, Darul sir, chairperson, please sir, say something about today's cases. I think sir has lost connection. Sir. Yes, sir, Rangnath sir. I think sir is Dr. Yashwant Rao sir, Treasurer IDC Professor, you are there?
Yeah,
yes, sir. Yes, sir.
Dr. Ranganath is there now?
Yeah, but I think he has lost some connection.
So, thank you, Dr. Jaideep sir, for having a wonderful 7th meeting of the series, sir. So we have 4 more to go.
Yes,
we'll have more better. Yeah, Ranganath sir. Sir, continue, sir. Ranganath sir.
No. Hello, hello,
Ranganath sir,
hello.
continue.
Am I?
Yeah, we are able to listen to you.
Manish, I think he has again left.
Yes, sir has lost connection. So thank you very much, sir, Dr. Jaideep sir, for fantastic. Sir, आगे. Sir, please. Yeah.
Hello,
Yes, sir.
hello.
Sir, you are audible.
Continue, sir.
Please. Yes.
Am I audible or not?
Yes,
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 sir.
yes.
Sir, we have a hospital called Fever Hospital in Hyderabad. All unsolved fevers will come there. There are 60 beds of pediatrics in that hospital, which has been named as Sir Ronald Ross Institute of Tropical Diseases. There, what is our observation was, first thing, because it was during the period of malarial more incidents, so malaria used to be the first, second used to be the typhoid, the third used to be the brucellosis, and the fourth used to be drug fever. So the pattern of treatment used to be stop all drugs, restart the game. That means you re-examine and you write your own notes and then submit it to the professor. He will decide what has to be done. All the drugs that were used to be stopped and restart the game we used to do. In this, all the three what I mentioned, in addition to that, we used to get Hodgkin's disease as fourth one. So this was the experience in a fever hospital. But here, our Jaideep has shown many cases which usually we may not be able to guess also as a case of PUO. So it was a very excellent and good session. Thank you.
Thank you very much, sir. Yashwant sir, sir, please give vote of thanks.
So I thank Jaideep sir for having a wonderful session on PUO and common errors in management of fevers. Our today's panelists, Dr. Neminathan, Tanya ma'am, Shrija ma'am, and Silki Agarwal ma'am for taking out their valuable time on this Thursday night. Thank you one and all for sharing your knowledge and imparting to each and everybody. And wonderful comments by Balasubramaniam sir and Eveles sir. Thank you.
Thank you. Thank you very much, sir.
Thank you.
Thank you, everyone. And
Thank you.
hope to see you
Thank you,
again on
everybody.
another Thursday night. Thank you. Good night,
Yeah.
sir. Good night.
Thank you. Good
ma'am.
night. Good night,
Bye.
Jaideep. Good night, Mr. Sir.
Night.
SP sir, good night. Darura sir, good night.
Bye. Bye.
Good night. Good night.
Good night. Good night.
क्या मनीष किधर गया? He has gone to.
कोई एक्सपायर हो गया, आई थिंक उसमें गए वो सर.
हाँ?
उनके कुछ
गुरुवार क्या?
क्लोज कोई एक्सपायर हो गया कोई सडनली.
अरे serious bad news for him.
Yes.
Right then, how is season
Yeah.
at your place?